Okay, so I already see the first question there.
Great presentation, and thank you very much for sharing all the great work that's going on at Stanford. The question is in the world of clinical trials, in the world of medicine and drug discovery and that sort of thing, there's just hundreds and thousands of articles and trials, some of which are bogus and some of which are good. And what you've talked about is a lot of how you bring the knowledge of Stanford together for Stanford. How does the rest of this corpus of knowledge sort of enter into diagnosis, prognosis, or treatment?
So how do we scale it outside of Stanford?
Or take the outside in as well. Yeah.
So we're part of multiple coalitions across the country. I'll name one, Coalition for Health AI, which is about 2,500 individuals across about 1,000 organizations who are freely sharing what they have learned and how it might apply, and asking others, what have you learned? We're amongst the founder sites of that, along with Duke, Mayo, and Hopkins University. So that's sort of the answer. CHAI.org is that entity, and is sort of parked under our Raise Health initiative. All right, so I have, instead of doing intros all at once, what I'm going to do is I'm going to do the intro, and then ask you questions, and we're going to do Fatima, Alex, and Michael. That's the order we're going to go. So Dr. Fatima Rodriguez is Associate Professor of Cardiovascular Medicine and Section Chief of Preventive Cardiology at Stanford School of Medicine. And you've done some amazing work on using AI for surveilling cardiovascular risk. So could you tell us a little bit more about your work and what have you found?
Thank you, Nigam, and I am the cardiologist in the audience, so I'm outing myself. I lead our preventive cardiology section, and I'm in the business of preventing heart attacks. And a lot of the time, we have information that's already sitting in imaging records that has information around cardiovascular risk. So I'll use the terminology correctly, as Dr. Shah discussed. Our group developed an AI algorithm to really classify the amount of calcium already existing in the coronary arteries, which in turn really relates to your risk of having a heart attack. Now, this algorithm performs very accurately and can give us this information on imaging data that's done not to assess cardiovascular risk, but for something else, maybe to follow up on a pneumonia or a lung nodule. So again, information that's already there. Now, I think the real innovation is exactly what Nigam talked about, is how do we get this to care delivery in the workflows that work for our many teams involved in healthcare. So what our group has done is in the context of clinical research, there was a question around research, we are trying to test that intervention. Who do we notify? Who do we involve? Notifying the clinicians. Hey, your patient had a scan. We picked up with an AI algorithm that they are at risk of heart disease and they have coronary calcium in their arteries. We recommend you start a statin. That's it. That's the intervention. And then we send a very similar message to the patient via Epic. And what happened? We found that over 50% of these patients who were at risk started statins, and statins are medications that are proven to reduce their risk of heart attacks. So again, a very low-touch, efficient intervention using AI, using data with a profound impact. And now we're really focusing, working with all the teams with how do we scale this? How do we reduce the burden on primary care physicians? Can we remove them entirely from the equation? How do we get our patients engaged on what's the best way to notify them that's both acceptable yet effective?
All right, so hopefully that gives a sense for how we bring medicine and tech together in the service of our patients. I'm going to move over to Alex. Dr. Weihan Chu, Clinical Assistant Professor at the School of Medicine and Associate CMO of our Tri-Valley Hospital. So you're responsible, like you're it, for the hospital here. So what are you seeing for AI in routine care delivery, and what are you excited about?
Yeah, I think it's good to reflect on where we came from. When I joined Tri-Valley in 2015, I was handwriting my clinical notes. In the middle of the night, if a patient gets sick and I couldn't read that cardiologist's handwriting, I was out of luck. Fast forward 10 years from now, we really do use AI on a daily basis in the hospital. A good example is we talked about the machine learning predictive algorithms. We've implemented them in the hospital to help us predict if a patient is likely to decline in the next 18 hours. The algorithm looks at a variety of data like blood pressure, lab results, diagnosis, medication that they're on, It makes a prediction to say like, hey, there are early signs that this patient may be getting sicker. That triggers an alert where me as the hospital medicine doctor, me with my consultants and my nurses to say, what can we do right now to change the outcome, right? How can we better optimize care? Are there different medications we can try? Are there testing we should do? Are there additional consultants we should bring on board now at this critical juncture to hopefully change the outcome? We can also plan escalation pathways. What if everything we do now does not help this patient get better? When they get sicker, where should they be? What is the best place for that care? This helps us minimize the need for emergency procedures that are unplanned. These are just some of the tools that we use. There's actually multiple algorithms running like this, predicting readmission rates, so our case managers can reach out to the patients after discharge to make sure they have follow-up care and they know how to take their medications. We have algorithms running in the emergency department that reads the electrical tracing of a patient's brain to let us know, like, hey, this patient is having severe seizures and you should reach out to a neurologist to get them involved in the care. On the other side of the coin, we talked about the language model. ChatGPT is all the rage. I actually do get to use it day to day, thanks to Dr. Pfeffer. We have a secure GPT version at Stanford where it's encrypted and it is not the same public version that we use. And that allows me to put more patient-specific information into the system, knowing that it is not going to be leaked and be used for training. Now, what I could do is I can customize my discharge summaries for my patient. When I write a discharge instruction for the patient when they go home from the hospital, I can copy and paste that into our secure version of the GPT, ask it to customize that at a specific reading level and sometimes specific languages, and then paste that back in for those patients. So there's truly a variety, and we talked about in-basket messaging too. In-basket messaging, it helps us customize the system creates a draft for the patient questions so that we can create personalized, specific, and contextually accurate responses. The clinical team then reviews that to make sure this really is accurate and make sure it's empathetic before we send it out. This helps us provide higher quality responses, not always at a time savings, but I think our patients ultimately benefit. And that really is the heart of the question, right? It's how do we, of all of the tools we use, how do these tools actually make people better? And the last thing is, we talk about dermatology being a hot field of publication in AI. Stanford published just recently, dermatologists versus dermatology with AI together, augmented dermatologists outperform dermatologists alone. The question then is, how do we bring that here into the Pleasanton community? We're now running a trial very soon locally with 7 radiologists to say, okay, we have radiologists working, they're very busy. Let's augment their interpretations with an artificial intelligence algorithm to help them with diagnosing. And would that then outperform radiologists practicing alone? I believe it will. I'm excited about it. And I'm proud to be a part of Stanford that we can bring these technology locally.
All right. So this example that Alex just gave is where Tri-Valley is ahead of our 500p and 300p facilities. We collectively call them 800p just for shorthand. And I want to share another anecdote about Alex, and I know you don't know what I'm going to say, so don't panic. So when the transition to electronic record keeping happened, there were a few doctors here who were closer to retirement, couldn't deal with the electronic scheduling. And Alex would print out their schedule, go to their home, and put it on their fridge. I'm not joking. So that the patient would not miss an appointment because the physician didn't know they were supposed to show up. Like, that's the level of dedication he brings to the table. So I had to share that. I mean, come on. So yeah. All right. And so Michael Pfeffer, our Chief Information and Digital Officer and Senior Vice President, Associate Dean at the School of Medicine, and Clinical Professor of Medicine. I would say amongst the best thing that happened to Stanford in the last 3 years. So Mike, you have 3,500 clinicians to support. and 1,200 plus technologies to manage. What's on your mind, and how do you make sense of it all?
Thank you, Nigam. Well, it means a lot. I mean, first, let me just say there's an amazing team in our IT department, which we call Technology and Digital Solutions, that makes all of this happen, really. And that is just such a pleasure for me to be part of. And as Rick said, I'm just incredibly excited about the potential of AI. We have, for years in technology, kind of enabled clinicians to do things, but not necessarily made it more efficient or more cost effective. We had to do that. We had to get from the paper world so Alex could read the cardiology notes, and digitize that to really turn it into something where we could capture the data, where we could start to see where the potential is. Now we are really moving into the digital world. So we've got, tons of opportunity now to really look at how these technologies can take the 20 years of getting from paper to the electronic world and actually make it something that is going to transform the way we care for our patients and for our physicians and clinicians to actually do their job in a more enjoyable way. So, 2 examples you've heard about here. I'm going to go into a little bit more detail because I think it's pretty fascinating. The first is the in-basket message that you were talking about. So we had an opportunity to be one of the first organizations to test this idea that a large language model like ChatGPT could write a response to a message that comes in through our patient portal to the provider, with the idea that this would save time. Now, you already know it doesn't. But what we've learned is that it actually reduces the amount of cognitive energy that clinicians need to spend on writing those messages. And it may not seem like a lot, but when you think about all the work that has to happen in a single day and all the shifting of your mindset from in-person visits to telehealth visits to calling insurance companies to responding to in-basket messages, any ability to reduce the cognitive burden is going to be a positive. Now, what's really exciting is this is just generation 1. As Nigam talked about, the model, the large language model, wasn't even trained on healthcare data. And we're learning how to prompt the model to do this better. So you can imagine in a year, it will save time and reduce cognitive burden. So that's our hope, and I think we'll get there. So remember, this is the beginning. We were one of the first to do this, and now we're rolling it out across our enterprise, and we're gonna learn, and we're gonna make it better, and we're gonna save time too. That's my hope. The second big one, and Rick mentioned this, is this idea of having an AI companion or scribe listen to the conversation between a provider and a patient and write a note, not just transcribe what happened, but actually synthesize it into an actual document that then the clinician will review and sign. And this is transformative. We were the first actually to pilot this technology with Nuance. It's a company that Microsoft now owns, to really understand how this was going to work. We have 50 providers across 17 specialties try this out. Not every physician loved it. I will say that, and that's okay. This isn't going to be for everybody, but the majority did love it, and the patients loved it because that interaction between the provider and the patient was no longer interrupted by the computer. And the accuracy of the history that the patient gave was recorded and was better. Because you can imagine, you see 20 patients in a day, and then you try to remember all the details when you go back and write the notes. It doesn't work very well. So this captures that in real time. And again, this is generation 1. So as this thing gets better and better and better and transcends into different use cases like nursing, so we're going to be one of the first organizations to pilot this for nurses in the hospital to give them more time with patients instead of at the computer. I really believe this is going to transform healthcare. And the list goes on and on and on. And I just want to reinforce with Nigam's leadership as their chief data scientist, our incredible data science team, as well as the entire IT department, that's sole job is to make Stanford a better place for patients and our clinicians. They're really the ones behind this kind of power. So I'll turn it back over.
So I hope this gives you a nice flavor for the kinds of things that we're doing. And I would invite people in the audience to ask questions. You could use the microphone or stand up here. What is on your minds as you think about AI? Please.
Could you talk a little bit about privacy and how you ensure the patient's privacy? Obviously, you need to share it across your sites and providers, collaborators, et cetera. And are you thinking about edge computing to be asked or add their security?
All right, I'm going to give that to Mike.
Thank you, Nigam. Privacy and security, I love it. One of the things that's always on my mind is security and privacy, because you've probably heard lots of healthcare organizations being targeted by malicious actors, and that's really a shame, because healthcare organizations do good things, yet are under attack. So how do we handle this? First off, all the models have to conform to HIPAA compliance. So when we run a model, the model is contained such that it cannot be trained on patient data when it's a commercial model. And we try not to let the data leave, or only the minimal necessary data leave, to run that model. So for example, when we use technology behind ChatGPT, we have a special version of it that doesn't allow the large language model to be trained on any of the patient data. The patient data doesn't stay with the model. It's kind of sent and returned. And that's all done in a very secure environment. We do both on-premise or edge computing kind of use cases. We also use the public cloud, but we do that in our own instance that's heavily secured to make that happen. From a privacy standpoint, again, the data is not shared outside of Stanford, unless it's at the request of the patient or through patient care initiatives. Say if you go to another healthcare organization and they've connected into us to provide interoperable care. Did I get that? Okay.
All right, I'm going to draw Fatima into the conversation a bit. You interact a lot with patients in the context of your research studies, getting their thoughts about AI and who should see their information and whatnot. So what is the patient perspective? Could you bring that here?
Yes, and we actually have a patient representative in our study who joins all our meetings. We have this poor guy, Doug, writing grants, writing papers. But his perspective is very important, because I think all the patients' perspectives, just like Mike just saying, the way we use the AI is minimal. So I said, again, we could probably do this exact project by looking physically at every single CT scan. But what the AI allows us to do is to do this more efficiently, do this at scale, and go back into imaging repositories. Now, the patient's perspective is like, okay, if AI is using our data, and we get these messages on Epic, is our data not secure? Is our data not private? So I think that's an appropriate response. Again, in the context of research, we have a lot of standards to protect patient data. But in the context of clinical use, I think that is an appropriate question for patients to ask their clinicians. But I think patients may say, why are you not using AI? And I actually do get that. I'll get the patient sending me a message saying, can you use that AI algorithm I heard you talk about to give me a number for how much calcium I have in my arteries? And, so I think our patients are getting savvier. Now, even as a user of Stanford Health Care myself, even for my kids that are Stanford Children's, they'll tell you, we're using AI to prompt the first part of the answer to this question. So it's important that our patients know when AI is being used, but it's important for our patients to be reassured that at the end of the day, the decision is always with the clinician. The clinician has full oversight, and so does the health system. So this is not AI ever acting in isolation.
All right. Please.
Thank you so much. This has been wonderful. I'm Yolanda Kishenko. I'm Executive Director of PEGI. And my question is related to protecting patients from predictive data being used to affect their rates for payers. So how do you take something like a prediction that you're going to need statins or you're going to need something else from impacting the patient negatively in terms of being labeled as uninsurable or seeing their rates rise or something like that?
I'll just specifically on the statin example. So one of our physician leaders asked a question. Now we're giving a patient potentially a diagnosis that we wouldn't have known about. And my response to that is, it was actually already there. We're just making it actionable. So I think that if you looked at the CT scan, there was already atherosclerosis or calcification in the arteries. It was already in the report. And again, what we're doing for the AI is to bring it out. But you're absolutely right, and this is something I worry about, is the equity implications, right? What if we have certain groups being afforded less things because of AI? So I mean, there's a lot of frameworks for looking at fairness, looking at equity, and that has to be considered in every single model that we deploy in our health system.
So individual level price change based on prediction is actually prohibited by law. So there's strong legal protections in place. If an entire zip code has that issue, then they are allowed to raise a price differently by zip code. There was a hand up back there, yes.
Thank you very much. And
mic
thank
will
you very
come to
much for your time there. This has been excellent. Question I have, you touched on earlier about, for physicians, cognitive stress, shall we say. Can you share a little bit more about, with articles over the last number of years about more and more physicians are retiring earlier for a number of reasons, stress being one, overload with their panels, et cetera. So can you share with us some of the implications of artificial intelligence and how you see that perhaps improving or bending the curve for the trajectory of early retirements for physicians? Is my question clear, first of all?
All right, I see Alex
Yes,
jumping in.
I can talk about it.
Thank you.
I think I've been in that forefront of helping with the transition. And my hope is artificial intelligence will make technology easier to use and not harder. On a typical day when I show up to the hospital, I review data, truthfully, thousands of data points within that first hour or two to try to make a lot of very quick clinical decisions on how to stabilize that patient, come up with a comprehensive plan to move that patient's care forward. The cognitive burden truly is significant, and we saw earlier you make thousands of decisions a week. My hope is, earlier we saw that graph that Dr. Shah showed where there's multiple data points across time. It truly is a limiting factor for a doctor to be able to go back through hundreds of pages of data, hundreds of lab results. My hope is AI will help to surface and organize that data in a more usable way for doctors so we can make higher quality decisions in less time. Ideally, it's like what we see in dermatology and radiology. AI will help augment our ability to diagnose, suggest diagnosis that may, truthfully, my hope is it will help surface diagnoses that I am not considering, that I may be missing, and treatment plans that may help improve that patient's outcome. So over time, as AI continues to progress, the hope is it organizes my day for me. It helps me write my notes for me so I'm not staying as late. And it helps make me more accurate as a physician and provide better, higher quality care. And that hopefully will help extend my career a little bit longer.
All right, please.
My naive understanding of artificial intelligence is that you give the computer data and you say, well, this should be the correct answer, and then you work it out, and then boom. So it's going back and forth until the accuracy of the prediction matches that. Now, it's been well said that to err is human. How do you control the wrong diagnosis or an alternative diagnosis to train those models to go back and forth? If you could help us with that.
Do you want me to take it? So great question. There's actually a decent amount of work going on what's colloquially referred to as data mixtures, or the data diet on which you train these models. The good news is that there's some nice math that shows that you don't need perfectly labeled data to learn good models. And the way it works is that if you have randomly labeled 50-50 error rate, you can never learn a model. Anything less than that, you can overcome it by adding more data. Usually, though, at 10 to 15% error rates, your data requirements get so large that it's not practically possible. But with the size of data elements that most health systems have in the 5-ish million patient range, it's possible to tolerate 10 to 15% error rate. So that's sort of one sort of technical way in which it doesn't have to be perfect. Some error is okay. The second thing that is often done is that you can select good data on which you choose to learn from. And those two things taken together allow us to essentially overcome the majority of the issues that arise from labeling errors. That said, the structural issues that certain populations getting different care or certain insurances not covering certain procedures and so on, that is notoriously difficult to get rid of because that's baked into your data set. Your model is only going to learn what's in the data. So some things we can overcome, but not everything. You want to say something?
No, I agree. It's a really great point. I think one of the challenges just in general in healthcare is thinking about this as better than what we do today as opposed to perfect. The algorithms are going to make mistakes. I mean, there's no way that it's going to be perfectly predicting all the time. But if it's significantly better than what we have today, and this is the augmented discussion of a physician who doesn't use AI will be replaced by a physician who uses AI, we want to do better. And then we want to learn when the model makes a mistake and why did it make a mistake, and then go from there. And that's why, for decision making and things, there's always going to be a physician in the loop, so to speak, to interpret that. And how we present the information to the clinician is also important. So we could just say, do this. We could say, do this because, or we could say, this is what we think. Here's like the probability, and take that into account with the other things that you're doing. So it depends on the risk of the algorithm, what it's doing, and kind of how confident we are that it's going to be making the right decisions. But I think it's kind of like the self-driving car problem, right? One self-driving car hits someone, we stop the whole thing, and that's terrible. Don't get me wrong, but humans hit people all the time, and that's not good either. So if the self-driving car can do better, then that's a win. And likewise, I think we're going to see in medicine better predictions that are going to help physicians do better. The other example which we're working on, which I'm really excited about, is pharmacogenomic decision support. It basically says, if we take your genome, and your genome has variants, and in those variants is how you interact with different medications. A lot of times right now we don't know that, so we guess. We say, here are 3 blood pressure medications or 3 statins or whatever, choose one. But if we better know how they're going to affect you because of your genomic variants, then we can provide that decision support to the clinicians. Is it perfect? No, but it's going to be better than what we do today. And that's another example of augmented intelligence. The algorithms behind it are actually not that complex, but it allows us to really move towards that personalized medicine feel that we want to really get to.
All right, there's a question in the back, and then the next one up is up in the front.
Hi, I'm a lean consultant, and as I look at this, are we using the medical record and AI as 2 separate entities, or are they being worked together into, are we integrating them? So we are integrating, we're not copying and pasting from one system into the medical record.
Can I take that?
Please.
When we think about deploying AI at scale, it has to be within the workflow that the clinicians are doing, or the patients are doing, or whatever. If it's outside of that, then it won't ever work. Now, we test things potentially. We can do things like proof of concepts or pilots where, it may not be completely integrated in, but the end state has to be fully integrated. So when we send a prediction, we send a message, we summarize something, it's within the electronic health record or within any of the other systems where that's happening. Because you're right, it won't work if you're copying and pasting things in and out of systems. It's all built in to the system. So we've built a data science platform at Stanford Health Care, which can run basically any algorithm and then push that prediction or the result of the algorithm into basically any one of our systems.
And just to add to, I think there's actually a tremendous amount of work being done on every implementation. Not just like from every question from who should see this message. Is this the doctor? Is it a nurse? Is it the scheduler? Where in their workflow should they be seeing this? And once they do see it, what is the expected action? And how do we track the outcome over time? So these are questions that really Nigam's team has led a lot of thought on making sure we don't just deploy models, but a significant amount of work is being spent to understand how are we actually using these models to get the most value out of them.
All right.
Hi, thank you for the presentation, very insightful. My name is Amarinder, I'm a technologist. You can put me in the category of people who build things to sell them. Sorry, Nigam. So my question is on Gen AI, and specifically Gen AI being targeted on administrative workflows, non-clinical workflows. Because I feel like the strength of Gen AI is not even generating emails or content, but it is designing interfaces that are intelligent, where the interface knows what the user needs at the right time and makes it available to the user at the right time. And because we can kind of train the LLMs to call for other systems and applications, right, like reducing workflows like scheduling and all of that. So is there any work happening within Stanford? I know, Michael, you mentioned about generating emails, but beyond that, is there any work happening on just the non-clinical administrative burden that clinicians face and the staff faces?
So it's a great question. Yes, it's not usually something I talk about because it's not too sexy when we talk about the back-end workflows, but you're absolutely right. I believe that we can virtually eliminate physicians having to bill or the revenue cycle in the next few years. I mean, it's completely automatable with large language models. So what happens is a physician has to come up with the codes for the diagnoses that they would bill for during the visit. We should be able to read the note and pull the codes out and send that to the visit, and on and on and on, whether it's hospital billing or professional billing in the clinic. So yes, we have a couple of different projects going on in the revenue cycle space, but my hope is we can completely eliminate physicians, clinicians having to do the rev cycle. Not only that, we'll probably get more accurate as well. The argument on the other side of that is we're gonna have bots fighting bots, health system bots fighting insurance bots on who's gonna deny what. So that'll be fun. I guess it's better than physicians fighting insurance companies. We'll just have bots fighting bots from the insurance companies. But yes, I think there's tremendous opportunity to automate the tasks that physicians really just don't have to do. If you write a note and you say what the patient has in the note, why do you then have to code that into ICD-10 code and then pick a CPT code, which is basically the level of the billing that would need. So there's all these things that have to go into billing that we could automate completely. And so I think we'll get there in the next few years.
All right, the mic's in the back.
Hello, my name is Ryan. I am a pharmacy resident at Tri-Valley. Really appreciate you guys being here. I saw this online right before I started. I just started yesterday at Tri-Valley. Love it so far. Yeah, that's why I'm in the scrubs. I know I didn't get the memo. Everyone here is wearing like really nice clothes. My question though is, as a resident, I'm really curious on which clinicians are gonna have access to this AI system. So how do you see that in terms of using it for not only doctors and physicians, but also for people like me? And then what cost goes along with that? Like, is that cost put on the patient? Is it put on us? Like, where do we get that budget from?
I think we should let Rick take that one, right?
For starters,
Rick is very generous.
You have Secure GPT right now at securegpt.stanfordhealthcare.org.
Just in terms of medical education, and I think that's like not just for physicians, but for everybody involved in the care team. I think that's a huge promise of AI. And we heard some examples of my colleague teaching people how to do ablations, but you could imagine other examples of somebody has patient education. So patient education, you're a pharmacist, you're doing a medication reconciliation with someone. Can you have a module for that patient on that kind of drug? Right? And again, all of that could be tailored to the exact reading level that's appropriate, the exact language, prior auths, coverage. Again, there's so many use cases in the pharmacy realm, drug-drug interactions that could kind of be brought up to the forefront before you discharge a patient, which is extremely dangerous. So yeah, I think when we say, I think we've been fairly physician-centric because we're physicians, but I think we mean the entire health system, and really it's a team. Our nurses, our registration clerks, right? We talked about some examples of that may be the first person who sees our patient in the emergency room. And that individual, maybe there's flags that can say, hey, there's an alert, this patient is at higher risk, let's triage them differently.
I just want to add, because I think it's a great question, it allows me to brag about our education technology team, which do amazing work. So first, the in-basket note generation. We actually, as part of the initial pilot, included a bunch of pharmacists who actually loved the technology the most. They scored it the highest. So we will be rolling that out to our pharmacists who do manage patient messages coming in for refills and things like that. So that's one thing. In terms of residents and medical students, and our theory, and I think it's the right thing to do, is we have to train all of our incoming physicians, clinicians, nurses, pharmacists on this technology. We can't just expect them to do med school the old way or pharmacy school the old way and then, oh, by the way, here's AI, have fun, figure it out. So we are building education tools around data science and AI for all of our trainees. We've going to use the AI scribe technology we talked about. All residents will have that capability to use. So it's not just going to be the attending physicians, it's the residents as well. But really thinking about how do we teach and train all of our future clinicians in all specialties on how to use AI and data science for taking care of our patients.
All right, there's any other further comments? All right, please.
Hi, my name is Bonnie, and I'm a healthcare consultant. I have a question about equity. How do we ensure all the stakeholders' inputs are incorporated when designing and building the AI?
So I'll just speak about it from the user perspective. You're right that you have to have everybody at the table, and it's always more people than you think. And I do health equity research, so often I'll have people come to me after they build a tool and they say, can you just really quickly look at this and make this equitable? That's the wrong time to talk to me, right? So this needs to be at the design stage when you're developing technology. So this is, and it really has to be throughout the whole life cycle of the technology and the AI algorithm and the implementation. So it just depends. So I think the answer to that is depends what the technology is, who's the intended user, who's it intended to benefit, and those are the people that need to be at the table. The work that we're doing around the coronary artery calcium and AI really started off as an equity question because there's actually a pretty significant out-of-pocket cost to have a special cardiac CT scan in the Stanford system. It's $325, which is extremely expensive for a preventive test for the general population. So now again, we're saying now this is an opportunity to identify those people who may not see me in clinic seeking prevention, right? And I think there's opportunities to enhance equity by using those in those specific populations. But the answer is really, it depends, and it has to be a priority before you design the product.
It's a great question. We actually just hired a chief health equity officer for all of Stanford Medicine. So it's really, really exciting because this is so important to us. One of the things I think, Nigam talked about, but I want to give him and his team incredible credit for this, is the idea that it's not necessarily the algorithm that's going to be biased or have an equity problem. It's the workflow. So let me give you an example. Nigam mentioned we could deploy an algorithm that predicts no-show rates for clinic appointments, right? And the algorithm itself doesn't have really any of the protected class information in it, but it can pretty well predict who's going to show up and who's not going to show up for the appointment. So there's two ways you could handle the output. One is you could double book. So we could double book appointments. In that case, you end up with an equity problem, or you could end up with an equity problem if both people show up. How are you going to see two people at the same time? Or you could, for those patients you predict at a higher rate for not showing up, you could call them and remind them and offer them transportation. Big difference in the workflow. Big difference in how they're equitably handled. And so I really believe, and again, this is built into how we assess algorithms, the workflow is so important in making sure algorithms perform in an equitable way.
All right. I have lost track of where the microphone is. Oh, there we go.
Hi, I'm IC Kriti. I have the privilege to be part of Stanford Health Care's Technology and Digital Solutions. I have a couple of questions. One, could you help us understand how we as patients, part of the community, help influence what solutions are selected and deployed and how folks go about it? And second, I know we've talked a lot about what solutions are being selected and prioritized and what intentionality goes within Stanford. Can you speak about what is Stanford Health Care or Stanford Medicine doing to influence how others, or electronic medical record companies, for example, are prioritizing things? So one from a patient standpoint, one from industry standpoint. Thank you.
That's a me question? Okay, let's see. Let's talk about the industry influence. So I think this is done, as Nigam mentioned, through various organizations that we're part of to really think about how to do this in a fair and equitable way. And it's less about what to do and more about how you do it. That's what we're really trying to influence. I think trying to influence what is really, really hard because there's so many creative people and there's infinite number of problems in healthcare to solve. So it's less about that. But healthcare problems are also local. And so some algorithms may work great at Stanford, but not great even at Tri-Valley. And so we have to look at how algorithms or problems that we're trying to solve occur at all our different sites of care and around the country to really determine what it is we want to focus on. So when you think about, how do we get tremendous amount of feedback from our patients about what's working well and what isn't working well. And we can take that and then see, are there problems we can then solve using AI, and then run it through our kind of firm assessment, which is what Nigam talked about, to see, is it actually going to work and provide value to all those parties involved? So there's many ways that we then kind of source that to determine what it is we're going to be working on.
All right. You see the microphone there, yeah?
My name is Wei Ming Oh. I'm actually the patient of Stanford Health Care. So I want to know how close we are for me to really see one actual AI doctor. And then another question is how AI industry really can believe human being is going to really want to see an AI doctor.
And you firmly believe we're all real?
I believe we're all real.
I think long before you see an AI doctor, you will see doctors who use AI to help care for you. I don't personally see AI completely replacing physicians, truthfully, in the next decade or two. And I don't personally see it at all. But I'm actually very curious on Dr. Pfeffer and Dr. Canola.
Yeah, I think that's an interesting question. I'll say that I just joined some wellness app, and they said, hello, I am a bot that will be your coach. and I didn't like it. I was like, oh man. But I'll tell you, this bot is really helpful. This bot is like, hey, have you logged your steps or things like that? So I think we all have to get used to it, but it's not the idea that we have. And the reality is that there's something beyond data that is really important for patient-physician interactions, and that's not going to be replaced. But I think all of us use tools to augment our practice. As a cardiologist, I still keep up with internal medicine, but it's impossible to keep up with all the guidelines. I look stuff up just like everybody else. So I'll look up stuff in things like UpToDate or maybe PubMed. And I think the role of AI will be to help me be up to date, have the best data when I myself make the decisions, and also help me identify blind spots, which we all have, about conditions that I may not be thinking about. So I'm a huge believer that it's going to help me be a better physician, but not replace what I do clinically.
I think it's a great question. We are all real, which is, last I checked at least, although I'd love to have another version of me, so one of me could be in Hawaii and one of me could be here. I don't think AI is ever going to replace doctors or clinicians. I have yet to see AI put in an IV, so I don't think that's going to happen. But there's I'm extremely privileged to have the opportunity to take care of patients in the hospital, which is often the most vulnerable time in a person's life. When you come into a hospital and you basically give up, your privacy, you give up your space, and you let people you've never met kind of take care of you and have very intimate conversations. And I don't see AI ever doing that. And when we get sick, it's not the same thing as having an AI coach or trying to schedule a restaurant appointment or all the things that we do now currently. We want empathy, we want help, we want to be listened to. We want to have someone put their hand on our shoulder and say, I've got you. And that AI will never do. So I'm a big believer that AI is going to make physicians better at what we do, faster, more efficient, and we'll be able to take better care of patients, but it won't be through a AI version of us.
All right. This device here is telling me that we're kind of out of time, but I still want to take like a few minutes and go for a lightning round with the panelists, and we'll go from Fatima, Mike, and Alex. What makes you optimistic about what's to come?
So I'm very optimistic about the role of identifying diseases early, using, again, cues that we already have, electrocardiograms, imaging data, so that we can find diseases before they strike or even manifest. And I think Stanford is really at the forefront of that.
I would say true precision health. So that's going to occur in two ways. One is we automate the things that physicians shouldn't be doing so they can spend more time thinking about patients. And then we provide truly personalized decision support so that we make the right decision for you in real time.
Actually, same vein, really that precision care that takes into account all of your medical history and information that we have that are difficult to utilize well now, and then provide measurably better outcome for our patients.
All right, AI for better outcomes with high precision. I love it. So I would love to thank our panelists. Please join me in thank you for taking the time with us, and I'll hand it back to Rick to close us out.